Waiting for the recording. Thank you, Jamie. Our topic for today is substance-induced depression. So we're going to take a look at medications that have been associated with increasing depression symptoms. From an objective perspective, we are going to list medications that have been associated with substance-induced depression. There are a handful. Some of them are probably expected. Some of them may be a little bit of a surprise. We're not, and it's not comprehensive. I will put that out there. I did try to pull as much as I could. There's an article that we based this off of that actually did a really nice evaluation and analysis on this, but it likely did miss some that just have one-off case reports. We're going to identify the time frame, so when might some of these occur, and then discuss some of the potential risk factors. So who may be at risk for substance-induced depression? Now, substance-induced depressive disorders is an official diagnosis within the Diagnostic and Statistical Manual. The diagnostic criteria requires that the mood disturbance with depressed mood or diminished interest or pleasure in most activities, these symptoms develop soon after exposure to the medication. So we really are looking from a time frame perspective at this is something that is new within a relatively short period of time from when the medications were started. Might be a couple weeks, might be a month, but we can really go back and identify they were not present when the medication was started, and we did see them not so long afterward. If we think about some of our mental health meds, it takes about 4 to 6 weeks to see a full impact, so not a surprise as we're trying to treat depression and anxiety symptoms, that if there are medicines that are also impacting some of those neurotransmitters, it may take 4 to 6 weeks to see some of those symptoms pop up. Symptoms of depression or the mood disorder do resolve in days to weeks after discontinuation. So spoiler, from a treatment perspective, it would be looking at tapering to discontinuing the substance and see if those symptoms all resolve. And then these symptoms can't be better explained by something else. It seems like it should be pretty straightforward. It was nice that we do have a condition within the DSM that speaks to this specifically, but it really is not. Some of the obstacles to being able to define prevalence, how often this happens, is we can't identify the total population. So at any given time, there may be prescriptions that have been written. Not all of the prescriptions that are written are taken. And especially here in the United States, we don't have a national database. Some of the European countries often are able to query their national database to get a full denominator of all of the patients that were prescribed, say fluoxetine, for example. They all picked it up, the medication, so we know at least what that exposure would be. We don't necessarily have that here, and it makes it difficult to be able to say, okay, of all of the people taking the medication, this is the number of folks that we see it in. I'm going to try to focus on some of the more common reports of substances that have been associated with depressive symptoms, but recognize that that is kind of an ongoing confounder to the data. For most of these situations, the patients are not just on one medicine and then those symptoms pop up. They have several other medical conditions that may make a difference and make some patients more sensitive. They may be on a number of other medications. They may be taking other substances that aren't necessarily over-the-counter or prescription medications that also could contribute. So we're not establishing causality. We are looking at an association, so that there is a correlation there, not necessarily saying this definitely causes it, but this has been associated with it. We see a relationship between the two, so we need to make sure that we're still screening. And that leads to the next one, the burden of causation. So because it is difficult to prove that it causes it as opposed to something else, that's part of why it does make the picture a little bit muddier than what we would want. But despite the fact that there are those confounders, these researchers did undertake a pretty robust analysis to be able to look at the risk of depression in patients that are on different medications. So they conducted this pharmacovigilance study using the FDA adverse event reporting system and querying it for over 20 years. So what did they do? They did a pharmacovigilance study. So they analyzed all of the reports that came to the adverse event reporting system from the first quarter of 2004 to the third quarter of 2024. So they were able to capture almost 20 full years worth of data. These reports, they were looking specifically for depression, depressive symptoms being identified and reported as the main thing that was seen, and that medications were the primary suspect, that it wasn't necessarily due to something else. They were able to look at some additional characteristics: age, gender, body weight, past medical history, comorbidities, medication history, so other medications that they were on, as well as onset of the medication and of symptoms for many of the reports. When they queried this data, they were able to find over 262,000 reports of patients who experienced depressive symptoms that seemed to be associated with the medication. So they had a really nice, robust data set to work with. As they pulled this apart, they wanted to see, okay, so who is it that was having most of these symptoms reported? What were the medications that they were using? And then what was the time to onset? So top indications for the medications, so the other conditions that were reported most frequently with patients who had depressive symptoms were multiple sclerosis, followed by depression, rheumatoid arthritis, smoking cessation, and contraception. The median time to onset had two little spikes, so 17 to 27 days. So really looking 2 to 4, 2 to 6 weeks, they started to see some of these symptoms. Now, I do just want to point out one of the confounders that they did identify and speak to is patients who have depression, who start using an antidepressant, may continue to have depressive symptoms. Their condition may continue to get worse, have greater severity of symptoms, even after they start the medication. So to reinforce that causality issue, we're using this medication to treat these symptoms. The symptoms are present, and maybe this hasn't been as helpful as we were hoping for. So what medications did they see that were associated with this? So I did list them out here for you. They're in reverse order. I didn't realize this till after I had done the graph. So varenicline actually was the most common. So the most commonly reported medication that had depressive symptoms, followed by isotretinoin, adalimumab, oxycodone, interferon beta, levonorgestrel. So it goes backwards, moving up with levothyroxine being here at the top. So a lot of variety in terms of the types of medications that are here. We're going to talk about mechanisms in just a minute. And I do want to draw your attention. So there are a number of medications here that are involved with other neurotransmitters, so that do impact a number of our neurotransmitters and may be used for mental health conditions: varenicline, quetiapine, bupropion, venlafaxine are all in there, duloxetine. We see a handful of medications that are related to the immune system. So we will come back to those interferons. Some of the monoclonal antibodies are associated with that, and then some agents that are related to inflammation. So rofecoxib being one of the examples that popped up in here. Interestingly, the number of reports of medications that are associated with depressive symptoms continued to increase from 2004 to 2024. The peak they saw was in 2015. There were more than 18,000 reports in the year 2015. So even though some of these medications were not approved in 2004, they were able to continue to capture that over time. Now, the likelihood that people would report may skew some of this data, but these were just the ones that were turned into the FDA database. So recognizing that there is that diversity, why? Why might these medications cause some of the symptoms of depression? One theory is that maybe there's causation because there is an impact on neurotransmitters and a depletion of some of the bioamines. So I'm going to take the two columns that are both on the side. We'll start with the depletion of bioamines first. So one of the theories, the pathophysiologic theories behind depression is related to our monoamine neurotransmitters, serotonin, dopamine, and norepinephrine. So agents that may impact these particular medications may have an impact on mood, concentration, appetite, sleep, interest, motivation, concentration. So they may, by impacting these neurotransmitters, they may directly result in a change in some of those symptoms where it may start to look like depression. Agents other than our antidepressants and antipsychotics that also impact some of those neurotransmitters, antihypertensives, as well as isotretinoin, that may be the rationale behind why we see that with those medicines. Some of the other agents are seizure medication, so impacting glutamate and GABA, as well as just overall neuronal signaling. And some of our chemotherapeutic and immunologic agents, they have a lot of other impacts, and some of the, especially the immune modulating medications, can have a direct impact on other neurotransmitters. So the cytokines can be active within the brain itself. By reducing some of the inflammatory cytokines, which is what most of our monoclonal antibodies are going to do, we use it to treat rheumatoid arthritis. We're trying to bring that inflammation down. That may alter the overall signaling. One of the potential theories that's come out as a result of this is there had been inflammation. Because there was inflammation, it may have signaled the brain to activate a number of neuroprotective pathways and neuroprotective functions, things like brain-derived neurotrophic factor. By reducing the cytokines, by reducing that inflammation, by blocking and targeting some of those inflammatory chemicals, it may turn off the body's signaling cascade, so they're no longer activating some of those neuroprotective functions. Unintended consequence by bringing that inflammation down, but that may be part of why we see that pop up with some of those substances. May also just be that there's neuroinflammation. So by having systemic inflammation, or in the case of multiple sclerosis, other inflammation within the central nervous system, it's possible there are other mechanisms that get kicked off that we're not able to target with things like the monoclonal antibodies. So by having them kicked off and the inflammation process started and continuing, it's possible that that may play a role for some patients with the development of depressive symptoms. Other potential routes, so hormonal changes. I'm going to focus on estrogen because those were the medications that did pop up. So estrogen does play a significant role in mood and emotional regulation. In some instances, if patients had lower concentrations of estrogen, by then giving exogenous estrogen, in the case of oral contraceptives, that may alter, again, some of those signaling pathways. The body was used to having this much on board. By having a much stronger signal, maybe it gets desensitized. It's like, whoa, 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 that signal's a little too loud. We need to tone it down. So it actually has an unintended consequence, because often we think of estrogen as being a little bit more protective related to that. Some of the other medications related to hormones may be blocking the effects of estrogen. So by blocking those receptors with things like tamoxifen, it can't then be protective and kick off the signaling cascade that really helps prevent the development of some of the mood symptoms like depressive symptoms. So it's possible by altering some of those concentrations and those signaling pathways, it can result in the depressive symptoms. One of the other pathways that's been a little bit better explored is the hypothalamic pituitary adrenal axis, the HPA axis. This one again goes back to inflammation as well as the immune system. So the HPA axis does regulate stress response as well as cortisol levels. So if there are conditions where there's chronic stress, chronic inflammation, it's possible that the cortisol levels are much higher. The body has gotten used to those levels being higher, and that's how it's been functioning. By bringing the inflammation down, all of a sudden that message is much softer. It's not nearly as robust because the body's not creating as much cortisol because we've interfered with that process. That may potentially alter some of the other neurotransmitters. We know that cortisol plays a role with mood and cognition. It directly can impact both the hippocampus and the prefrontal cortex. So its direct actions may not look like they should result in depressive symptoms, but by no longer having those elevated cortisol levels, it is possible that we can start to see some of that. It's also possible that it had kicked off, again, neural inflammation, and that process continues, even though in the periphery, we're targeting some of that inflammation with things like our corticosteroids, so prednisone, methylprednisolone, for example. So it doesn't have to only fit in one box, which is likely why we see so many different medications that have been associated with depressive symptoms. None of these is a direct, yes, this is absolutely 100% what it does. They've all been theorized and they're being explored mostly in laboratory type models. So lots of different causes, not exactly sure what each specific cause is. So how robust is this data? How much can we rely on it? Some of the medications have been categorized because they're repeatedly reported to be associated with depressive symptoms. This particular table is based on, there is evidence of causality. It's based on randomized controlled clinical trials. So introduction of the medication, we see the adverse effect. Removal of the medication results in resolution. And in a number of cases, reintroduction of the medication resulted in those symptoms coming back. Discontinuation again resulted in resolution. So by having that secondary challenge, we do see that this seems to be medications that are very directly associated with depression. So strongest case for causality here. Medications we see on here are ones that impact the immune system. So our interferons, which is not a surprise, that's one of the major adverse effects that we think about. Some of our estrogen compounds, so tamoxifen being an example, some of our anti-seizure medicine, so vigabatrin, topiramate, levetiracetam, and tiagabine. Some of our antidepressants, which may seem like a little bit of a surprise. So the incidence being a little bit lower, but also being associated with that. So as we start to perturb and change those neurotransmitter concentrations, sometimes we're not getting the effect that we really wanted, especially if we're starting this for treatment of depression. As a reminder, though, this may also be used for patients who have menopausal or perimenopausal symptoms. It may be used in chronic pain. So it's possible that some of those other indications may also be contributing to the why we prescribe the medication and then the development of those depressive symptoms. And then efavirenz is one of our antiretrovirals. So again, likely involved with the immune system. There's another table that's been identified. So this is a little less robust evidence to support. So there is potential causality. There's definitely an association, but we're pulling this data from other sources. So non-randomized trials, observational trials, cohort studies, case controls, retrospective studies, case series that they've done. So number of reports, yes, has gone up, but we're not able to always see that clear link. And in many of these cases, we don't often see that re-challenge to say, okay, this happened one time. Do we always see that happen a second time? For this particular category, similar types of medications. So you see anti-seizure medicines, agents that are involved with the hormone process. So gonadotropin releasing hormones, oral contraceptives pop up here. Isotretinoin, which is involved with some of our other neurotransmitters, as is methyldopa and varenicline. So still falling under the umbrella of causes that we saw, but just not quite as strong evidence as what there is with the prior table. So still more likely than many of our other medicines, but not quite as much as those first group of medications. So recognizing there's a bunch of medications that are on there for your epilepsy patients, you may have to use one of them. I'm going to pick on phenobarbital. So there are some patients that just respond really well to phenobarbital. They may not respond quite as well to some of our sodium channel blockers like phenytoin or carbamazepine. So if we get efficacy with that, we may have to use those medications. So how much of a risk might these patients have for developing depressive symptoms? Well, it depends. There have been two particular factors that seem to be more likely associated with the development of those depressive symptoms. One is a history of depression. So if a patient has had any type of depressive episode in the past, whether it's a substance-induced depression previously or a depressive episode without medications being involved, they may be more sensitive to the changes in some of the compounds and more likely to experience those depressive symptoms. So we may want to screen them a little bit earlier. The other factor that they found also seems to be associated is psychosocial stressors. So kind of an external factor. So external pressure where without the medications, maybe patients don't have significant depressive symptoms, or they're more subclinical symptoms where they're not reporting them. They're maybe they have a little trouble sleeping, but not enough where it's causing problems. We add the medication on board, and that may be just enough to exacerbate those symptoms to make them much more problematic. So both internal factors, the history of depression, as well as the external stressors may put patients at risk for this. So what do we do about it? Screening is going to be important. For most of the patients, if we're commonly using some of these medications, let's get a baseline. Where do you stand with your depressive symptoms? Many primary care offices have this built into their workflow. So it is fairly seamless as patients check in, they fill out their checklist, and now you've captured some of that baseline data. You know where the patient is starting. And if we've got that built in, especially into some of the electronic medical records, it can make it pretty easy from a follow-up perspective to have them do repeated rating scales so that we can track what those symptoms look like over time. Ideally, we'd like to capture that they're getting worse before the symptoms really have exacerbated to a point that it's causing impairment for the patient. If we recognize those symptoms have popped up and there seems to be a medication that was started in the not too distant past, so really 2 weeks to about 2 months being the window where we really should have high likelihood that this medication may be involved, let's see if we can discontinue the medication. Can we taper it down? Can we pause it? Can we swap to something different? And see what happens to those symptoms. Again, once the medicine is stopped, we can see resolution of the symptoms if it is substance-induced, but it may take a little bit of time. Oftentimes, the symptom resolution is between a week and a month to see full resolution. If we can't, so vigabatrin being a good example, it's used for fairly refractory seizure conditions. If a patient requires that and it's treating their seizure disorder, it's possible we can't get them off of that. We can't use another medicine because they haven't worked. So can we treat the depression if we need to? So non-pharmacologic treatment options, especially things like psychotherapy, can be beneficial. And then pharmacologic treatment, really not trying to treat side effects with more medicine. So this would be reserved just for patients that have moderate or really severe symptoms. There's not a lot of data to support treatment of substance-induced depression with other agents, and antidepressants are listed as some of the substances that may result in substance-induced depression. So we really want to try to reserve that if we can. Get rid of the offending medication is definitely preferred, and then look at some of those other non-pharmacologic interventions, including physical activity, to see if we can do that to treat the symptoms instead of adding another medicine. So in summary, mood changes have been reported with a number of medications from a variety of classes. So screening patients, especially as they're starting new medications, can be really beneficial so that we can track that and hopefully get out in front of it. Discontinuation is going to be your main intervention. If we cannot do that and we do suspect that the medication has contributed to that, really preferencing some of those non-pharmacologic interventions. That is my presentation for today. I will stop my share.